Well, hello once again, everybody. My name is Kwa, lecturer of anatomy, physiology, and medical terminology at Homebang University. And today we're going to talk about the thorax and abdomen once again. And we'll actually be looking at the liver and biliary tree, which are two very important components of the abdominal cavity. All right, so now in today's lesson, we'll be exploring the liver as well as the structures that are related to the liver, like, for example, the ligaments of the liver, as well as the segmental anatomy of the liver. We will also be exploring the gallbladder, what it does, as well as the biliary tree, which is basically the series of tubes that connects the gallbladder to the liver, as well as to the duodenum, which is the first part of the small intestine. All right, so what's up about the liver? So the liver is actually the largest visceral organ in the body. In the body, the biggest organ is actually your skin with the biggest surface area. But the thing is, if you're talking about which organ in the body is the largest in terms of visceral organs in your abdominal cavity and the thoracic cavity, the liver is going to take the cake this time around. Okay, so the liver is around 1.5 kilos in weight, okay, averagely. And it's actually is the largest visceral organ in the whole body. And some functions of the liver includes detoxification of blood that's coming from the GI tract via the portal vein. And in the GI tract, we have this venous system called the portal venous system. The portal venous system is unique for the digestive tract, and it brings blood from the digestive tract to the liver before the livers detoxify that blood and send it back into the venous circulation via the three hepatic veins that go back to the IVC, inferior vena cava. Okay? And the liver is going to also metabolize substances. One of the substances that it metabolizes is going to be bilirubin. It's going to convert bilirubin into conjugated bilirubin that can be soluble in liquids. All right. So, and also the liver is going to help the synthesis of proteins like plasma proteins like albumin. And therefore, if the liver is going into failure, then albumin in the blood is going to decrease significantly, which also decrease the oncotic pressure of the blood. Okay, you will learn more about that in physiology. The liver is going to also produce bile, which is very, very important in terms of the digestion and absorption of fats in general. Bile, you usually would hear that bile is going to be concentrated in the gallbladder, but please do not be mistaken that bile is produced there. No. The bile is going to be produced in the liver first and then sent through a series of tubes into the gallbladder. Okay. And also the liver is going to help you with the production of cholesterol via the intrinsic cholesterol producing pathway. So as you can see here, the liver does a lot of things. And therefore, the liver is very, very important in the human body, and you cannot really live without one. Now, the location of the liver is primarily going to be in the right hypochondriac region, and as well as the epigastric region. It extends over a little bit into the left hypochondriac region. So if you see here, this picture on the right, it depicts the 9-region division of the abdomen. You have the 2 hypochondrium or hypochondriac regions over here, the right and the left. And then you have the epigastric region over here. Now, the liver is going to extend from here, which is the right hypochondriac region, over to the epigastric region. And a little bit of a tip of it is going to extend over to the left hypochondriac region. So the liver is actually a very, very big organ. All right, so now let's talk about the surfaces of the liver. There are the diaphragmatic surface and the visceral surface of the liver. Now, if you look at the liver from anterior, which is here, to posterior, you will see that the liver has this surface here, right? That is called the diaphragmatic surface of the liver. You would wonder, wait, why is it called the diaphragmatic surface of the liver? Well, the reason is because it is in very close contact with the diaphragm. The diaphragm is this sheet of muscle, remember, that divides the thoracic and abdominal cavity. So this part right here, this surface is called the diaphragmatic surface of the liver. Okay. And also the liver has a visceral surface. The visceral surface is mostly down here. okay? Mostly down here on the inferior portion of the liver. And the liver also have a bare area. And the bare area is here, right here, okay? The bare area is this portion right here that, as you can see, is not going to be covered by these membranes right here. These membranes are called the peritoneum. And therefore, this bare area right here is the portion of the liver that is not covered by peritoneum. Okay, this is very important and you need to know it. Now, this here, okay, this here is a very, very good representation, artist representation of the diaphragmatic surface of the liver. Okay, and underside from this, you will see that if you get the liver and you flip it, okay, you flip it up, you will see that on the underside of it, this surface on the underside of it is going to be the visceral surface of the liver. All right. Now, the diaphragmatic surface of the liver is smooth and domed, and it lies against the inferior surface of the diaphragm, right? Diaphragm is here. Inferior to the diaphragm is here. You got the diaphragmatic surface of the liver right here, okay? Now, the diaphragmatic surface is going to be associated with the subphrenic and hepatorenal recesses. The subphrenic recess is this space right here, a potential space that lies in between the diaphragm and the top of the liver. Now, the hepatorenal recess is this right here, which is basically a pouch, okay? Basically a potential space that lies in between the liver and the right kidney only. Okay, so the liver is going to be in contact with the right kidney, but not the left. Okay, this is very important. You need to know it. Okay, and the liver tends to push the right kidney down just a little bit more, and therefore the right kidney is always going to be more inferior in location than the left kidney. But now let's go back to the hepatorenal recess. Okay, this recess right here is also called in clinical setting the Morrison's pouch. Okay, the Morrison's pouch is going to lie in between the liver and the right kidney and adrenal gland. Now, a very important clinical correlate of this is that the hepatorenal recess is one of the first places that peritoneal fluid, which means the fluid inside this cavity here in brown, the peritoneal cavity, if there's any fluid in that cavity, the fluid tends to accumulate first in the hepatorenal recess or Morrison's pouch. And therefore, if you look at the ultrasound, okay, of the liver and the kidney, you will see that the space right here, the potential space right here that is represented here by a line is Morrison's pouch in between the liver and the right kidney. Now, if there is fluid within the peritoneal cavity, it tends to go to this pouch first, and you will see this black or anechoic line that extends in between the liver and the right kidney like this, okay? This is an area or a position that is very frequently checked for in the fast ultrasound technique in the ER, okay, in the emergency department, because it will help us localize if there is any fluid, free peritoneal fluid within the abdominal cavity at all. All right, let's move on. Now, if you flip the liver, okay, now you get the diaphragmatic surface of the liver and you flip it, okay? You flip it this way, like this, woo, okay? And you will see the visceral surface of the liver. The visceral surface of the liver is going to be covered with visceral peritoneum in almost all aspects, except for this part, okay? Except for this part that is covered by the gallbladder, okay? And this part is called the fossa of the gallbladder. Now, do not be confused about the fossa versus the actual gallbladder itself. The fossa of the gallbladder, you can think of it as the part of the liver that the gallbladder sits on, okay? And because the peritoneum is going to extend from here in the visceral surface, and then it's going to go over the gallbladder to the other side, therefore, the underside here of the gallbladder fossa that is deep inside here is not going to be covered by peritoneum. So how many areas in the liver are going to be not covered by peritoneum, by visceral peritoneum, that is? There are two, okay? You need to remember that there is a bare area, okay, and also a fossa of the gallbladder that are not going to be covered by peritoneum, okay? This is important. There will be questions on the exam about this. Okay, now the visceral surface of the liver, just like in the lungs that we have seen previously, it has indentations corresponding to other structures, making impressions on the liver, including the esophagus, including the right anterior part of the stomach, superior part of the duodenum, lesser omentum, the gallbladder, like here, the right colic flexure, the right transverse colon, and the right kidney and suprarenal gland. All right, so now let us go over some of these impressions on the liver. We have here the gastric impression, which is going to be the impression for the fundus of the stomach, okay? So imagine, you have the underside of the liver, right? So you have, let me see here. There we go. So we have the underside of the liver like this. Imagine we're looking at it from anterior to posterior. The liver is going to look like kind of like a triangle shape like this, okay? And now you have the esophagus going down here, and then you give out, okay, a stomach right here. You see that? Okay. And all of this stuff is going to be behind and under the liver, if you will. Then there will be an area right here, the liver, that is going to be indented, right? And so that area corresponds to the gastric impression right here. So the impression of the gastric impression is going to be the impression of the fundus of the stomach, okay? And then when the stomach becomes the duodenum right here, it's going to indent the liver once again right here. And that would be the duodenal impression just right here. Just in a similar manner, we'll have the colic impression, which is the impression of the colic flexure, which is the right colic flexure, aka the hepatic flexure, okay, of the colon. And then you will have the renal impression. Now, guys, anybody of you who have studied medical terminology, what impression is this for again? What organ fits in here? The right kidney. That is correct. Okay, remember, the liver is not going to be in contact with the left kidney. The only kidney that is going to fit in here is going to be the right kidney. Okay, RK, the right kidney. So those are the main impressions that you need to know. Okay, the gastric impression, duodenal impression, colic impression, and renal impression. But do remember that we have more impressions over here as well. Okay, and do remember to review it if you ever need to do it. Okay, all right. Here are all drawings. Let's continue. All right. So in the visceral surface, you also have this structure right here that is circled in this image right here. Okay, this structure is called the porta hepatis. Okay, and the porta hepatis you can think of as the hilum of the liver. Okay, remember when we talk about pulmonary hilum, which are the hilum of the lungs? So this stuff is the same, except it's for the liver. Okay, it serves at the point of entry into the liver for the hepatic arteries, which are these things in red here, and the portal vein, which is this thing in blue, as well as the exit point for the bile ducts. Okay, the bile ducts is going to go out from the liver like that and like that, pass through the porta hepatis, going out. Okay, like that. All right, and so we also have some associated ligaments that is associated with the kidney, with the liver, I'm sorry. Okay, so we have the falciform ligament, which is this ligament right here. Okay, the falciform ligament, you can see it way better on the other surface of the liver, the diaphragmatic surface. So let's back up just a little bit. Okay, so we have here, you see the falciform ligament extending all the way here. Okay, it is going to be made up of these two different layers, and those two layers is going to continue through the right side and the left side, and those continuings of the falciform ligament is going to form like, you know, a layer of the coronary ligament of the liver. Okay, now just notice very carefully here that on the underside or the inferior side of the falciform ligament right here, you have this ligament right here that enters into between the two layers of the falciform ligament, right? So this ligament is called the ligamentum teres, or the round ligament. Okay, let's look at it a little bit more on the visceral surface. All right, so the falciform ligament is here. The round ligament is this ligament right here, okay, that leads on to this, okay? And then it's going to continue as this groove right here that is called the ligamentum venosum, okay? The ligamentum venosum is eventually going to go right here, pass on to the inferior vena cava, all right? We're also going to have what is known as the lesser omentum, and the lesser omentum is going to have two ligaments, the hepatogastric and the hepatoduodenal ligament. the hepatogastric ligament is going to connect the liver to the lesser curvature of the stomach. And the hepatoduodenal ligament is going to connect the liver to the duodenum. For these two, though, we are going to see them in much more detail when we look at the peritoneum lecture. Okay. Now, remember when we talk about the falciform ligament and how over here it's going to form two ligaments that are going to extend on the superior side of the liver, right? So those two are going to be the right and the left anterior coronary ligaments. Okay, so all of this, you can call it the anterior coronary ligament. Now, on the posterior side, you also have this, okay? And this is going to be the posterior coronary ligament, okay? Now, just as before, look at the orientation of these coronary ligaments. This is the anterior coronary ligament, okay? And what does it look like? What does it connect the liver to? The diaphragm, that is it, okay? So the coronary ligaments, both the anterior one in this picture, as well as the posterior, okay, as well as the posterior coronary ligament, they have the job of anchoring the liver to the diaphragm, all right? Now, at the ends, okay, at the ends of them on the left side and the right side, okay, these coronary ligaments, the anterior and posterior ones, are going to converge, okay? And because the conversion looks like a triangle, on the right side, you have the right triangular ligament, okay? And on the left side, you have the left triangular ligament, which are the convergence of the anterior and posterior coronary ligament, and also is going to attach the liver to the diaphragm that is more superior to it, all right? So those are some of the ligaments, okay? You have also the round ligaments of the liver, also called the ligament teres hepatis, okay? And this round ligament is the remnant of the left umbilical vein in utero. Now, remember when we are in utero, okay, the pulmonary arteries and veins, they do not work, okay? Because the fetus, they can't use their lungs yet. And therefore, what we have instead are going to be the umbilical artery and the umbilical vein, which play the same role as the pulmonary veins and arteries, all right? So now, for the umbilical vein, okay, umbilical vein is going to be kind of like the pulmonary vein. So if that is the case, what kind of blood, is it deoxygenated or oxygenated blood, is going to be present within that umbilical vein? Is going to be oxygenated blood, right? Because the pulmonary veins carry oxygenated blood back to the heart. So the umbilical vein is the same thing. It's going to travel from the umbilicus all the way up here to the underside or the visceral surface of the liver, and it's going to bring oxygenated blood to this area. But then it doesn't stop there, okay? But it turns into this duct here in utero, okay? This duct here in utero is called the ductus venosus, or the venous duct, okay, in utero. And that venous duct is going to bring oxygenated blood all the way into the IVC so that it can go back to the heart, okay? It's weird, right? But that's how it works in utero. Now, in the adult, we don't need these structures anymore. We don't need the umbilical vein, and we don't need the ductus venosus anymore. So these two turns into ligaments, okay? These two are occluded, and they turn into ligaments. Now, the ligaments for the umbilical vein, it's going to turn into the round ligament. And for the ductus venosus, it's going to turn into the venous ligament, or the ligamentum venosum, okay? And that's why we have these two ligaments here on the liver that seemingly is doing nothing. All right, so now let's talk about the bare area. In this image, the bare area is right here, and that is the region of the liver that is not covered by peritoneum. That is correct, okay? So now, the anterior boundary of the bare area is indicated by a reflection of peritoneum, aka the anterior coronary ligament, aka this one here, okay, is going to be the anterior border of the bare area. Now, the posterior border is going to be indicated by the posterior coronary ligament, okay? Now, the coronary ligaments is going to come together laterally on both sides to form a right and a left triangular ligaments. We know that before, but remember very carefully, the anterior boundary, okay, is going to be the anterior coronary ligament, and the posterior boundary of the bare area is going to be the posterior coronary ligament. So it's just this region here in between, okay, that is not covered by any peritoneum whatsoever of the kidney, of the liver. All right, so the lobes, right? Now, grossly, the liver is going to be divided into 4 different lobes, okay? You have the left lobe, the right lobe, the caudate lobe, and the quadrate lobe, okay? Now, the term grossly here doesn't mean, oh, that's gross, okay? But it means that with the naked eye, you can see the liver being divided into 4 different lobes like that, okay? So now the 2 main lobes are going to be the left and the right lobe. And you can see the left and the right lobe the best if you look at the diaphragmatic surface of the liver, which is this surface right here, okay? Now, the left lobe is the one on the left here, and the right lobe is going to be the one on the right. And they are going to be divided by the falciform ligament, okay? Just right here, okay? Now, if you flip the liver from here and you flip it up, boom, you will get to the visceral surface of the liver. And on the visceral surface of the liver, you will see 2 more lobes, okay? So these 2 lobes, the caudate lobe and the quadrate lobe, are only visible on the visceral surface, okay? Now, the caudate lobe is the one that is more posterior, like that, and the quadrate lobe is the one that is more anterior, like this, okay? So actually, one question. When you look at the visceral surface of the liver, how do you know which way is anterior, which way is posterior? I'll give you a hint, okay? The IVC, the inferior vena cava, is always posterior, okay? And the gallbladder, especially the fundus of the gallbladder, is always anterior. So you see this, that's anterior. So you see that, that is posterior. And therefore, the caudate lobe is going to be more posterior, and the quadrate lobe is more anterior. Very nice, okay? Very nice. The left lobe is separated from the right by the falciform ligament anteriorly, and a fissure for the ligamentum venosum and ligamentum teres on the visceral surface. So where are those fissures? One, ligamentum, round ligament, okay, right here, and then ligamentum venosum over here. So this is left, this is right lobe of the liver, all right? So right lobe is the largest, the left lobe is smaller. The quadrate lobe is only visible on the anterior part of the visceral surface. Functionally, it relates to the left lobe, okay? And the caudate lobe is visible on the posterior part of the visceral surface. And here is where the kicker comes in. The caudate lobe can actually be thought of as a second liver. Can you believe it? Because functionally and anatomically, it is separated from everything else, okay? When we get to segmental anatomy of the liver, you will see that the caudate lobe receives its own segment, okay? That is separated from everybody else. Why? Because it is supplied by its own branch, okay, of the hepatic artery. It is supplied by, it is drained by a branch that goes back to the IVC independently. And it also have its own supply, the own output of bile. And therefore the caudate lobe can actually be thought of as a separate liver from the rest of the liver. Okay, that's kind of fascinating for me. I don't know about you, but that's very, very fascinating. Okay, now we have alluded it in the last section, but now let's look at the segmental anatomy of the liver just a little bit. All right, so now since the development of liver resection surgery, the size, shape, and segmental anatomy in the liver has become clinically important. Why is it become clinically important? It's just like in the lungs, guys, just like in the lungs. When you see that something is divided into segments, you know that the blood supply to each segment is going to be separate from another segment. You know that the output of each segment is going to be different than the other segments, right? And therefore, it's just the same thing as the liver, okay? It's just the same thing. The lungs would be the same thing of the liver. And why is it more clinically important to remember these segments? Because eventually you will have to resect a part of the liver. And how do you know which part of the liver is going to be safe to resect out without affecting other regions? Well, now you can know, because there are segments here that if you take out these segments right here, rest of the liver is going to function fine. All right. So it's very important, especially important in the resection for metastatic diseases, like for example, liver cancer and all that sort of stuff like that. Okay. Now, to get to these segments of the liver, first off, let us see how many segments there are. There are actually 8 segments of the liver. All right. And on the diaphragmatic or anterior part of the liver, you will see that there are segment 2, segment 3, segment 4, that is right here. Usually it's going to be called segment 4A and 4B. Okay, 4A is more superior, 4B is more inferior. And then you have 5, 6, 7, and 8. Okay, so 8 segments, right? Wrong, it's only 7 segments. So where's the 8th one? Okay, we have said from 2 to 8, that is right here on the diaphragmatic surface. So where is the 8th segment? It turns out that segment 1, okay, or also called the caudate lobe, okay, that, oh, I'm sorry, not this one, but this one here in red, okay. No, it's this one. I'm sorry about that. I don't know what I was thinking, but anyway, the whole of this one is the caudate lobe. The caudate lobe is actually its own segment, and it is segment 1. And therefore, if you combine segment 1 with every single other segment of the liver, it turns out you will have 8 segments of the liver. Okay. And now let's look at how these segments are actually done so that we can actually know how to divide them in a clinical setting. Okay. These segments are divided by 2 veins, if you can believe it. The hepatic vein that's up here, okay, and the portal veins that's down here, okay. Notice that I said 2 veins. That was incorrect. 2 types of vein, more like it, okay. So the liver, the segments of the liver are going to be divided using the right, the left, the intermediate hepatic veins superiorly, and the portal veins inferiorly. Okay, so now let's just imagine like this. You have a liver, okay, that is right here. Okay, I'm going to draw the liver like this with the caudate lobe being just right here, that is represented by, like, you know, this region right here that I'm drawing. Okay, that's caudate lobe. So now IVC is right here. Okay, and going into the IVC, we have 3 veins. Okay, those 3 veins are going to be the right hepatic vein, the middle or the intermediate hepatic vein, and the left hepatic vein, like this. So these 3 hepatic veins are going to divide, are going to be plane. Okay, this one is one plane. This plane, the plane of the right hepatic vein, is going to come down here and divides the liver like that. Okay, you see there is this portion here that is going to be divided from the rest of the liver by this right hepatic vein plane. Okay, same thing with the middle hepatic vein. It's going to go down here. Okay, and then for the left hepatic vein, it's going to go down here and divides like this. So these 3 hepatic veins actually divide the liver into 1, 2, 3, and 4 different sections. Okay, with the caudate lobe being its own separate thing. It's just chilling out. It's just hanging out here. It doesn't really have anything to do with the rest of the lobes, the rest of the segments. Okay, so just think of it as a separate entity completely that is right here. Okay, but the 3 hepatic veins is going to divide the rest of the liver into 1, 2, 3, and 4 big segments. Okay, and now you have the hepatic portal vein that is going to go on into the porta hepatis right here and divides into 2. And those 2, one running onto this way, that is the right branch of the portal vein, one running onto this way, which is the left branch. Now, we can use this plane here that these 2 branches off to divide the liver even more, okay, by this line here that is in the middle, and it separates, okay, and it separates the liver into an upper and lower half, okay, and that plane is the plane where the hepatic portal vein comes out. And therefore, because we have the hepatic veins dividing the liver in 4, and then you have the hepatic portal vein split that 4 into 2s. Okay, so now how many segments do we actually have here? Okay, so we have 2 over here, we have 3 over here, we have 4 over here, which is 4A up top and 4B down the bottom. Okay, So 4A and 4B you can think of as like, separate entities, but like, what they combine, okay, to make segment 4 over here. And then you have 5, 6, 7, and 8. Okay. So that's how the liver is going to be divided into segments. I teach you guys this very, very carefully simply because of the fact that it's easier to learn than the segments of the lung. Okay. So as long as you got your right hand, you can actually do a pretty neat trick. Okay. For the right hand, you can tuck your thumb into the rest of the fingers, and the thumb is going to be tucked in. Now, the tucked in thumb can represent segment number 1, which is the caudate lobe. Okay, so you can have this one here being the caudate lobe. Okay, segment 1. Now, for the rest of the fingers, you can see that there are 3 grooves here. 1 here, 2 here, and 3 here. And those 3 grooves can represent the 3 hepatic veins. You can see that the knuckles over here can represent the plane of the portal vein. And therefore, if you have your right hand, you can put it into this position and you can count the segments actually. Okay, you can count the segments using your right hand. How do you count it? Okay, so first off, you have number 2 over here. Right inferior to that is number 3. Okay, right to the right of that, you have 4A and 4B. Okay, and then everything else follows a clockwise orientation like that. So 5 is going to be here, 6 is going to be here, 7 is going to be here, and 8 is going to be here. Okay, so I know it requires a little bit more practice, but it's actually easier to master than the lung segments. Okay, and therefore you should learn this while you are still in medical school. That is my recommendation to you. Okay, so that's how the liver is going to be divided into segments, guys. Okay, so now let's talk about the arterial supply of the liver. The arterial supply of the liver is going to come from the celiac trunk, which is this artery right here. Remember, when we talk about the celiac trunk, we said that it divides into 3 branches. Okay? The left gastric branch over here, that's going to go to the lesser curvature of the stomach. Then you will have also the splenic, okay, the splenic artery. Okay, the splenic artery is going to go to the left side. Okay, now there is another one that is the common hepatic artery. The common hepatic artery is going to go to the right, and it's going to divide into 2. Number 1 is going to divide superiorly to form an hepatic artery proper. Okay, and it's going to divide down to form the gastroduodenal artery down here. So now let's look at the hepatic artery proper over here. Okay, because the hepatic artery proper is going to feed both the liver and the biliary tree. The hepatic artery proper is going to divide into 2. Okay, the left hepatic artery and the right hepatic artery. Sometimes, okay, it will divide into another intermediate hepatic artery, but most of the time, the left hepatic artery is going to be the one that gives off the intermediate hepatic artery over here. But what you need to know, okay, is that the hepatic artery proper usually gives off 2 terminal branches, okay, 2 terminal branches, the left hepatic artery and the right hepatic artery. And then the right hepatic artery is going to give off another branch, which is called a cystic artery, that is going to go and supply the gallbladder as well as the proximal portion of the cystic duct over here, okay? And for the rest of the right hepatic artery is going to supply the right side of the liver, and the left hepatic artery is going to supply the left side of the liver, okay? And the arterial supply of the liver is the one that mainly is going to bring oxygen, okay, to the liver. But if you're talking about bringing nutrients to the liver, you have to talk about the portal vein, okay? The portal vein, the liver is actually receiving a dual blood supply, okay? And in that dual blood supply, approximately 30% of the blood is going to come from the arteries, the 2 hepatic arteries over here. But 70% is going to come actually from the portal vein or the hepatic portal vein. Okay. All right, so now let us talk about the gallbladder, okay, the gallbladder. Now, the gallbladder is going to be the structure that is going to lie on the underside of the liver, right on top of the gallbladder fossa. Now, in this image, you can see that because of the peritoneum going to the gallbladder, okay, and then it's going to course over the gallbladder and going to the other side. You can see that is the reason why the fossa of the gallbladder does not have any covering by peritoneum, by visceral peritoneum at all. Okay, now the gallbladder is a pear-shaped sac lying on the visceral surface of the right lobe of the liver. It consists of these parts: the fundus of the gallbladder, okay, the body of the gallbladder, that is right here, the neck of the gallbladder right here, where a lot of gallstones tend to stuck, okay. Now, the neck has this thing here that is called the spiral fold, which is formed by the mucosal folds of the neck, okay. And the arterial supply of the gallbladder is going to come from the cystic artery. Remember, the cystic artery usually comes from the right hepatic artery, okay. All right, so now let us look at the biliary tree. We have the gallbladder here. That is the one that is going to store the majority of the bile and concentrates it, especially when we are not in the meal time. All right, so now the biliary tree does the job of conveying, okay, bile from the liver, because remember, once again, liver is the one that makes bile, and therefore these ducts have the means to convey those bile from the liver all the way to the gallbladder when we're not eating. And when we're eating, these ducts is going to conduct the bile from the gallbladder all the way to the duodenum so that we can use it in the digestion and absorption of fats. All right, now the biliary tree is going to extend all the way from the liver. Up here is going to be the liver, okay? And it connects with the gallbladder right here. And it's going to eventually empty into the descending part, or the D2 part of the duodenum. Okay, remember back, duodenum has 4 parts: D1, which is the superior part; D2, which is the descending part; D3, which is the horizontal part; and finally D4, which is the ascending part. All right, and therefore the bile duct eventually is going to drain onto the descending part, or D2 of the duodenum. Now, let's look at the tubes. Okay, let's look at these tubes in general. So now we have the right and the left hepatic ducts that are going to go out from the liver. Okay, so now these things are cut off here, but do you understand? Do you understand what, if we draw this thing out even more into the liver, what you will see? What do you see if you extend these ducts into the liver? Well, let's look at the segment another time. You see, this is the right hepatic duct and the left hepatic duct in green over here. You see that the tributaries for all of these hepatic ducts actually come from different segments of the liver. Why? Because hepatocytes can make bile, and each hepatocyte makes a little bit of bile, and therefore the output from all of those hepatocytes are going to go over here into these tubes, okay, the bile canals, and those bile canals are going to eventually coalesce to form the right hepatic duct and the left hepatic duct, okay? So the right hepatic duct and the left hepatic duct represent the whole liver output of bile, and they're all going to go down here and combine with each other to form a common hepatic duct that is right here. The common hepatic duct, if you are not eating, is going to convey the bile all the way here down to the common bile duct down here into the duodenum. But it cannot go into the duodenum because there is a sphincter right here, the sphincter of Oddi. The sphincter of Oddi, when we're not eating, is not going to be open. And therefore, we cannot go into the duodenum using the common bile ducts. So where does it go? It is going to go back up the bile duct into this duct here called the cystic duct, and into the gallbladder where the bile is going to be stored. Okay, the bile is going to be stored in the gallbladder and concentrated until we actually eat some food. And when that happens, our body signals the gallbladder via a hormone called cholecystokinin that it is time to let down the bile. And so the gallbladder is going to contract. Bile is going to go into the cystic duct, into the common bile duct, all the bile duct, going into the duodenum. And now the sphincter of Oddi will actually be open for the bile to flow in. All right. And that is how the bile duct works. Okay. So you can basically draw the structure out, guys. Okay. The right hepatic duct combined with the left hepatic duct into a common hepatic duct. The common hepatic duct is going to combine with a cystic duct, which leads out from the gallbladder to form a common bile duct or the bile duct. Okay. The common bile duct is going to go over here, down and open into the descending part of the duodenum, which is D2. All right. Okay. Actually, before we move on any further, I still need to talk to you about this little duct right here. Okay. That little duct right there is actually called the main pancreatic duct, or the pancreatic duct of Warsaw. Okay. And the main pancreatic duct in most people is going to combine with the common bile duct to form a big ampulla right here. Okay. You call that ampulla the hepatopancreatic ampulla, or the ampulla of Vater. Okay, the hepatopancreatic ampulla. 1 second, hepatopancreatic ampulla of Vater. Okay, so this ampulla here is going to be the common release of both pancreatic juice via the main pancreatic duct and the bile via the bile duct to go into the duodenum. And now I'm going to have to talk to you a little bit more about this opening right here. This opening is going to be called the greater duodenal papilla. Both of the pancreatic juices and the bile is going to go into the hepatopancreatic ampulla of Vater, and then eventually go through the sphincter of Oddi into the greater duodenal papilla into the duodenum. All right, so that's how it flows. So now there is a clinical correlate. Okay, there's a clinical correlate that if you ultrasound the liver and the biliary tree, and you happen to put your probe so that it transects the portahepatic region right here. Okay, so if it transects that region right here, you will see 3 structures. Okay, and those 3 structures is going to be looking like this. All right, there is going to be this bigger structure that is on the inferior. There's going to be this big structure that is going to be more posteriorly located in the body. This is going to be the portal vein, the structure in blue. There's going to be the bile duct that is more to the right side, on the more anterior side of the body, anterior and to the right. And the hepatic artery is more anterior and to the left. And therefore, combined together, they make up this orientation just like the face of Mickey Mouse. So we call this the Mickey Mouse sign. And in the Mickey Mouse sign, the face of Mickey is going to be the portal vein. Okay, the right ear, or actually on this image, it's going to be the left ear, so it's right here. Okay, is going to be the bile duct, and the right ear is going to be the hepatic artery. Okay, so very, very nice clinical correlate there for ultrasound. And then the second clinical correlate are going to be gallstones. And gallstones are present in approximately 10% of people over the age of 40. So it's actually quite a lot, okay? There's quite a lot of people over the age of 40 that has this, okay? It's a big prevalence, okay? Now, it's more common in women rather than men. And there are 2 most common types of the gallstone. There are cholesterol gallstones and the bile pigment gallstones. In them, the cholesterol gallstones are much more common. Okay, now the gallstones can be calcified and therefore can be picked up on X-ray and CT scan. Okay, the diagnosis of gallstones, these are the stones right here. Okay, those gallstones are going to be right here. Okay, these yellow structures that you see here on the gallbladder and along the biliary tree. Okay, the diagnosis can be a fasting ultrasound exam of the gallbladder, or an MRCP, which is going to be the magnetic resonance cholangiopancreatography. Those are just the 2 types of diagnosis. We can also use CT. We can also use ERCP. There are many, many types of diagnosis for gallstones, okay? Now, from time to time, the gallstone would actually impact the region of Hartmann's pouch at the gallbladder neck, right here. And when that happens, the gallbladder cannot empty normally, and the contraction will produce these pain periods. okay? And those pains are going to be intermittent. It's going to it's going to be off for a little bit, and then it's back on. Okay, so it's going to be pain, no pain, pain, no pain, pain, no pain. Okay, and we call that actually is going to be colic pain. Okay, colic pain is going to be intermittent pain, just like that. Now, if it persists for a long time, you may need to take out the entire gallbladder, and this process is going to be called the cholecystectomy. Okay, so cholecystectomy is the resection, or like basically the ectomy, or the taking out, okay, surgical removal of the gallbladder. So that would be cholecystectomy. Now, cholecystitis is going to be this inflammation of the gallbladder, and this inflammation will produce pain as what is known as Murphy's point, and the pain can actually also be referred to the left shoulder. All right. I'm sorry, this is wrong. It should be right shoulder, okay? So the pain can actually be referred to the right shoulder, not the left, okay? So please correct that. All right. All right. So right here, you can see that using ultrasound, you can actually see the calcified gallstone right here in the form of hyperechoic structures, okay? And right here, you can see that in an MRI, you can see that this one here is very, very distended. The gallbladder is very, very distended, and it can be a result of bioaccumulation, and there will be something blocking the way so that it cannot move down. Okay. Now, right here, you can see that this point right here, C. Okay. So this point here as C corresponds to a point that is the intersection of the right costal margin, which is basically the margin of the right rib cage, and A here, which is the midclavicular line. Okay, and this point C here is called Murphy's point, and Murphy's point is going to be the one that is going to be very important in the diagnosis of cholecystitis, because pain can be elicited if we ask the patient to take a deep breath and put your finger or your entire hand over at this Murphy's point. Okay. Now, the pain of cholecystitis can actually come from here initially, but then it can radiate over to the right shoulder. Okay, the right shoulder up here. And this phenomenon of referred pain, we will learn it much more when we get to physiology. All right, so that is all. That is the end of this lesson, guys. Thank you very much for sticking with me so far. If you have any questions, please put it in the comments or ask me directly in class so that I can get back to you as soon as possible. My name is Hua. Thank you very much once again, and I hope to see you in the next couple of lessons. Bye-bye.